My name is Aparna Keshavaya, and I'm a senior statistician at Mathematica. For several years now, Mathematica has been working with states to develop better data and evaluate new strategies to combat opioid misuse and its downstream effects. In 2016, we began exploring how wastewater testing, an environmental monitoring tool that the U.S. Environmental Protection Agency adapted for human health, could be used to address the opioid epidemic. The sheer scale and spread of the epidemic have made it impossible to control. According to an estimate from the National Institutes of Health, more than 115 people in the United States died from overdoses each day in 2017, with the epidemic spanning the rural-urban divide and now costing the nation more than $78 billion each year. Rural areas face particular challenges, not only because of poorer access to addiction treatment, but also because of inadequate data. Take Montana, for example. The map on the left shows opioid prescriptions by county, and there's a good deal of information and variability. But not all prescriptions are problematic, and if we instead focus on a more relevant outcome metric, drug-related deaths, the map goes gray, with virtually all data suppressed because deaths are relatively rare and Montana is fairly sparsely populated. Worse yet is the fact that we're in 2020 and I'm reporting 2017 estimates in this map, because the most widely used data sources have 2-year lags between when the data are collected and reported. And the data are fallible because people engaged in illicit activities and substance use are reluctant to report such. Clearly, we need better data, and that's where wastewater-based epidemiology comes in. Wastewater is a relatively new data source that can provide objective measures of drug use in near real time. I say relatively because when you look at the history of human tools and inventions, the first sewer system was developed 5,000 years ago. In the early 2000s, one of the first pilot studies of wastewater testing was conducted by the Office of National Drug Control Policy. And it confirmed the value of wastewater testing, particularly because it provides information on the amount of a drug being used in a community, and not just whether there was any self-reported use in the recent past, which is what survey data provides. But what is wastewater testing, and how do we get data from this source? Wastewater is a combination of household sewage, industrial runoff, and in some locations, stormwater. The sewer captures wastewater from 81% of U.S. households, missing only those served by septic systems. And because wastewater from different pipes combine before ultimately ending up at a centralized treatment plant, the resulting data do not reveal information about individual households and are not plagued by privacy concerns typical of medical data. At the treatment plant, wastewater testing involves a 3-stage process. First, you collect wastewater samples, typically 24-hour composites. Then you send the samples to a lab for chemical analysis, and finally you perform back calculations to translate concentrations of drugs in the sample to an average dose per person in the service area. Importantly, we can distinguish between drugs that were simply flushed with those that were actually ingested, because when our body metabolizes drugs, it converts them into a new compound that we can test for. So what we have with wastewater testing is a chance to intercept a stream of data that's continuously flowing beneath our feet. Last year, researchers at Montana State University conducted a multi-site wastewater pilot study in 2 sites in Montana, one urban, one rural, and asked Mathematica to help assess the policy value of the methodology. We analyzed weekly samples of wastewater collected over the span of 10 weeks, which covered between 1/3 and 1/2 of the entire county's population. We then compared estimates of use for 18 targeted compounds with local data on law enforcement drug seizures, emergency medical services overdose calls, and pharmacy prescriptions. When we looked at the profiles of drug use between the urban and rural site, we saw that the most commonly used drugs were the same between the sites: 2 opioids, codeine and tramadol, as well as amphetamines and methamphetamines, which are stimulants. But methamphetamine use was more than 6 to 7 times higher in the rural site than the urban site. These data point to the need to flexibly tailor funding, addiction treatment, and other resources to the substances that are spiking in a community. Next, we examined data from local law enforcement, focusing on the combined category of amphetamines and methamphetamines, because it was the only drug with more than a few seizures over the study period. We looked at the largest drug seizures, those shown in red, because those might actually take enough drugs out of circulation to affect a population level estimate of drug use. When we superimpose those large seizures over a graph showing weekly trends in methamphetamine use based on our wastewater data, this is what it looked like. After every major seizure, community use of methamphetamines decreased, with two exceptions. But these exceptions may be explained by the fact that the drugs seized could have been amphetamines rather than methamphetamines. And indeed, when we looked at the wastewater trendline for amphetamines, we saw that the pattern was preserved, with community use of amphetamines declining after the seizures. So by overlaying wastewater-based data and law enforcement data, we could clearly see the effect that each major drug seizure had on community drug use. Next, we looked at data on calls placed to emergency medical services for a drug overdose. What we expected to see was that calls to EMS for overdoses involving a particular drug would surface after high levels of use of that drug in the community. And that's what we found. After weekly estimates of tramadol use in the community spiked, we saw that an EMS call was placed for an overdose involving tramadol. Even when the wastewater data are sparse, there's practical insights that can be derived. For example, heroin can be challenging to detect in wastewater, and in our study, many wastewater samples had concentrations that were too small to reliably detect. But even so, with only 3 reliable measurements, we saw that after heroin use spiked, there was an EMS call for an overdose involving heroin. And this pattern generally held up for each drug and across both sites. Finally, we looked at prescriptions filled based on data from one of 2 pharmacies operating within the rural site. We compared the trends in doses of a drug in the filled prescriptions with trends in doses excreted into the wastewater. For example, when you look at codeine, the trend lines are very similar. When one goes up, the other goes up. When one dips, the other dips. But you'll notice that there's a lag, with the orange line changing first. And this makes sense because the prescription fill date is likely to be earlier than the actual prescription use date and therefore excretion date. Next, when we looked at methamphetamines, we get a different story. The main aspect that stands out from the graph is that wastewater-based data suggests much more methamphetamine use in the community on absolute terms than the pharmacy data. And this makes sense because the pharmacy may not be the main source of methamphetamines, which is also manufactured on the black market. The beauty of wastewater is that it gives you information on drug use regardless of where the drugs came from, and the level of detail that is provided has great value for policymakers. You can test a single sample of wastewater to get a snapshot of the mix of drugs being used in a community, which can provide an early warning for new drug threats. You can also test samples repeatedly over time to gauge trends in drug use, which can be used to assess the effectiveness of a new program. Wastewater testing can also be used to pinpoint geographic hotspots or concentrations of use, which allows for a data-driven approach to targeting resources. And finally, the methodology has great value because it provides unbiased measures of drug use in a manner that is scalable. Wastewater testing relies on a fairly consistent infrastructure for sampling and testing that was developed in the 1970s as part of the Clean Water Act. In Europe, officials are already using wastewater testing as part of a multi-pronged strategy to monitor drug use, combining wastewater data with data from other sources and using triangulation to fill in gaps. And the Australian Criminal Intelligence Commission routinely uses wastewater testing to assess operational priorities. Looking into the future, wastewater can be used for much more than drug epidemics, providing a window into the health of our communities. With wastewater testing, we can assess changes in chronic disease prevalence, infectious disease outbreaks, vaccine coverage, and medication compliance. Ultimately, by simply tapping into a stream of data that already exists, we can stem public health issues before they explode into crises and epidemics. I'd like to end by acknowledging contributions made by the researchers at Montana State University, who worked to collect the wastewater samples and data from local agencies, and my colleagues at Mathematica, who helped generate the visualizations and comparative analyses. If you're interested in learning more about how Mathematica is partnering with government, foundations, and other research organizations to combat the opioid epidemic, visit mathematica.org. Thank you.